Okay, so in this video, I'm going to talk about a very important subject under the topic of medical treatment of surgical patient. I'm going to talk about what we call the coagulatory status perioperatively. Okay, how to deal with the coagulatory status of a patient pre, during, and post surgery. Okay, so actually, this topic is a great challenge to the physicians, and the reason behind that as a physician, you are afraid of risk of coagulation in surgery during surgery, okay, and on the other hand, you are afraid of risk of bleeding, okay. So your duty as a physician is to balance this two, okay. You don't want your patient to get into coagulation, okay, and on the other hand, you don't want your patient to bleed too much, okay. And your work is to keep your patient away from this and away from that, and this is what we're going to talk about at this video, okay. So to make the great benefit of that, I just would like to start it and to explain it with steps, okay, starting from the coagulation risk. As I told you, the surgery itself is a risk for coagulation, okay, and we also have other risk factors, and the presence and absence of these risk factors will increase or decrease the risk for coagulation in a patient. Like what? Like the age of the patient. The more the age of the patient, the older the patient is, the more the risk for coagulation. Okay, and if the patient is obese or not, obese patients are more prone to coagulation. Okay, the presence of fractures, the presence of other comorbidities, just like malignancies, just like previous surgeries. Okay, and previous history of DVT or any coagulatory status. Okay, some drugs also are risk factors for coagulation. And smoking, of course, is very important risk factor for coagulation. Okay, so to make this more organized, the surgeons or the physicians categorize the patient of coagulation into three categories: low risk for coagulation, middle risk for coagulation, and high risk for coagulation, depending on the factors that I just mentioned. Okay, so to categorize the patient into one of these groups, you start with the nature of the surgery, whether it is minor or major surgery. Minor surgery is associated with low and moderate risk for coagulation. Actually, it's not pretty much associated with high risk for coagulation. Okay, so the first thing you look whether it is minor or major surgery. If you think it is minor surgery, then you look for the other things, the presence or absence of other risk factors, just like obesity, comorbidities, smoking, and so on. If you find there are no other risk factors, then this is a low risk for coagulation. If you find that you have other risk factors, then it is a moderate risk for coagulation, because minor surgery plus trauma or illness or any family history or risk factors, it is a moderate risk for coagulation. Okay, so this is the first point. Now let's move to the major surgery. If you have a major surgery, it may be associated with low or moderate or high risk for hypercoagulable state. Okay, so if you have a major surgery, how do you decide whether it is low or moderate or high risk? You look at the timing of the surgery. You look for the age of the patient, the presence or absence of other risk factors. The age of the patient is less than 40, okay, and he has no other risk factors, then it is low risk for coagulation. If the age of the patient is above 30 or and he has other risk factors, then you categorize the patient as moderate risk for coagulation. If the patient having particularly cancer, okay, cancer or trauma or ortho surgery, then it is associated with high risk for coagulation. Okay, so these are the main categorization of the patient into low, moderate, and high. And why do we categorize the patients into these three groups? Because the treatment, the management of the patient, or the prophylaxis given for the patient of surgery is related to this. Okay, so mainly we deal with the patient coagulatory status with two measures. The first one, which is the mechanical measure, like the leg socks, like the pumping, okay, leg pumps, calf pumps, like the early mobilization of the patient, the good hydration of the patient, and so on. Okay, this is the first thing to do, the mechanical measures, and we do it for all patients, low, moderate, and high risk. Okay, and the second thing is the pharmacological treatment of the patient, or pharmacological prophylaxis of the patient, whether it is warfarin, aspirin, heparin, low molecular weight or high molecular weight, or unfractionated, I'm sorry, okay, pentasaccharides, and so on, okay, antiplatelets. These pharmacological agents are not given for all patients. They are only given in high risk for coagulation, sometimes in moderate risk for coagulation. We give these agents. But the main question that this video is really focusing on, is if the patient already on anticoagulants like warfarin, for example, how to deal with this patient if we are planning him for a surgery. Okay, if the patient is already on warfarin, so you have to look to the other side of the equation, to the bleeding, okay, the risk of bleeding, So if the patient is with low risk of bleeding, then you can most of the times continue the anticoagulant that he is already on, okay, but you have to monitor the INR during that. If the patient is of high risk of bleeding, you have to stop the warfarin. And what do we mean by low or high risk for bleeding? The high risk of bleeding is associated with heart valve replacement surgeries, coronary artery bypass, the abdominal aortic aneurysm, bilateral knee replacement, and so on. Okay, the low bleeding risk is associated with cholecystectomy, abdominal hysterectomy, gastrointestinal endoscopy, these minor surgeries. Okay, some of them are major, but associated with low risk of bleeding. So if we have a low risk of bleeding, then we continue warfarin and we monitor the INR to be within the normal range. Okay, if we are in the high bleeding risk region, okay, so we have to stop warfarin. And how to stop warfarin? Actually, it depends whether we are planning for an elective surgery or an urgent surgery, sub-urgent surgery, or immediate surgery. Okay, if we are planning for an elective surgery, we stop the warfarin 4 to 5 days prior to the surgery, because it takes the warfarin about 4 to 5 days to resolve the effect of it. Okay, so we stop it 4 to 5 days prior to the surgery. If we are planning for sub-urgent surgery, which means surgery that will be within 2 days, then we stop the warfarin immediately and we give vitamin K. Okay, and the vitamin K doses will be lower. Okay, but if we're planning for an urgent surgery within 1 day, we stop the warfarin, we give vitamin K, and we also give vitamin K in higher doses, okay, than when we are dealing with a surgery within 2 days rather than 1 day. Okay, so we give higher IV doses, about 2.5 milligram per deciliter. Okay, and if we are planning for a surgery just right now or within minutes or hours, we have to stop the warfarin immediately, and we have to give vitamin K in high doses, and we have to give fresh frozen plasma. Okay, so these are the things to do when we give warfarin. But the important question now is it logical in a patient with high risk for coagulation, okay, and high risk of bleeding? If he is in high risk of bleeding, we said that we stop warfarin. But what if he is also in high risk of coagulation? How to deal with such patients? In such patients, we have to replace the warfarin, not stop it, just stop it like this. La, we have to replace it by other anticoagulants, just like the unfractionated or the low molecular weight heparin. Okay, and actually the low molecular weight heparin can be given once daily or twice daily, depending on the factors we are giving. Okay, if we are giving, for example, the inoxaheparin, okay, we give it once daily. If we are giving the delta heparin, we give it twice daily and should be stopped 12 to 24 hours prior to surgery. Okay, but if the patient is with high risk of bleeding, we stop it 48 to 72 hours prior to surgery. Okay, now the unfractionated heparin is more effective. It can be monitored by the APTT, the clinical bleeding of the patient, okay, the occult bleeding in the stool. Okay, so this is how to monitor it, and it should be stopped about 5 to 6 hours prior to surgery. And this process of giving the unfractionated low molecular weight heparin instead of the warfarin is actually what we call bridging. Okay, bridging. And it is, we bridge in the patients of high risk of coagulation. Okay, high risk of coagulation and high risk of bleeding. In the patients with low risk of coagulation, we just stop the warfarin and we don't have to give anything. In patients of moderate risk of coagulation, we stop the warfarin and we just deal with each case individually, depending on the risk factors. Does it need to give the bridging, the unfractionated low molecular weight heparin, or no? Okay, so this is how to deal with the coagulation. If we have low risk of bleeding, again, we can easily, most of the times, just continue the warfarin without any interrupting. Okay, so these are the outlines of how to deal with the coagulatory status of a patient perioperatively. And don't forget that you have to continue the warfarin post surgery just when the patient starts to eat, at about 12 to 24 hours post surgery. Okay, 12 to 24 hours post surgery, you give the warfarin, and you also have to bridge because it takes the warfarin about 4 to 5 days to re-establish. Okay, so like just like pre-surgical status, post-surgically, you have to bridge the warfarin with heparin and low molecular unfraction or the unfractionated heparin, depending on the bases I just talked about. Okay, and this is all I want to say about this topic. Thank you very much for watching this. See you in another video.